Welcome to a new episode of The Doc is In. I would like to take the opportunity to introduce my colleague, Dr. Immaculada, who will be sharing this session about talking about pediatric allergy in Cleveland Clinic, Abu Dhabi. Will be a very interactive conversation, and we will be able to cover as much as possible in pediatric allergy.
Hello. It's a pleasure to be with you and to be discussing this very interesting topic. I would like to start saying that allergies are very prevalent. Are chronic conditions that affect about 30-40% of the population, but in pediatric age it can be even higher. One of our areas of interest here at Cleveland Clinic Abu Dhabi, Allergy and Immunology Department, is food allergy. And so what do you think, Dr. Hamad, are the most important or prevalent allergies here in the UAE?
Well, from my point of view, like I see that it is similar to that allergy that is like common in European country. But as you know, like sesame is very common in our cuisine, and the prevalence of sesame allergy is very high. Plus, we have also patients who have like the tree nuts, like for example, like the pistachio, cashew is also very common allergy in here in UAE. And also, I would say also the common one, like for example, especially in the toddler, like the egg and the milk, these are the common in this specific age group.
Maybe we should distinguish between what are the most common ones in younger kids, milk, egg, fish, that kids develop these symptoms when these foods are firstly introduced in the diet, right? So the mom gives for the first time or second time some egg, and then the kid breaks in hives, for example. And as opposed to older kids or adults where fruits, vegetables are more common. And I would like to, because everybody keeps in mind nuts, peanuts, and all the efforts or main efforts, particularly in schools, are directed against nuts and tree nuts. But we should keep in mind that other allergies are also relevant. So teachers, the rest of the staff in schools, and also in restaurants should be aware of many different allergies. So it's not nuts and tree nuts.
I totally agree with that. But I would like to ask a question regarding like the early introduction of food. Is it better to early introduce different allergen at a very early age stage, or should we wait and introduce these allergen food later in life?
That's a very good question. So when I did my training, we used to postpone, and we used to tell parents to delay the introduction of allergenic foods. But we've learned recently in the last years that the earlier we introduce the foods, the better. And we have strong evidence for peanut, for egg, and this is probably true for most of the foods. So now the advice is when we start diversifying the diet in babies around the age of 6 months or a bit earlier if the baby is ready, we should introduce all allergenic foods. We shouldn't delay. And this has been linked to reduction in the incidence of allergies.
I agree with you. And one of the main landmark study, which was like the LEAP study, which is learning early about peanut. So when they did this study, they introduced like the peanut in a very early age, and there was significant reduce of the risk of developing peanut allergy in kids. Can you elaborate anything like something about the study?
So this study, it was very interesting observation from previous studies. So those there are regions where peanuts, and this is commonly in the Western countries with peanuts or other nuts, were introduced much later in life, when the kid is 3-4 years old, because of the risk of choking, right? So we don't want babies to have a whole peanut kernel or a whole pistachio kernel. So the advice was, okay, we need to be really careful. We need to be safe. So we had quite high incidence of these allergies. But other regions, the situation was different, and babies were offered snacks, popcorn covered in peanut butter. So in these regions where this was the case, the incidence of peanut allergy was much lower, with a similar ethnicity, similar introduction of other foods. So they say, why? This maybe it's because the peanuts are given differently to the kids introduced. So this clinical trial was in London, and it included kids from different backgrounds, different ethnicities, and some of the babies were given peanuts very early at the age of 4 to 6 months, while others were advised to introduce later in life. So those kids that were given peanuts initially had a much lower incidence of peanut allergy by the age of 3 years old. And that was a really breakthrough. Yes. We learn a lot. All the allergy community learn a lot. And after this study, some other groups became interested. And I think you were part of one of the studies with
the heat
egg.
study with the egg. So we did the study with the egg. We introduced the egg like at very age. We started by the age of 4 to 6 months introducing the egg. And it was really show some protection of reducing the risk of developing allergy later on in life. Then I have another question. So I will have a lot of questions from you, who were like a lot of parents ask this question. So if you were just saying that it's better to introduce like allergy food item in the diet as early as possible. Do we need to do any screening test before we do introduce these food, or should be it done like at home without any testing?
That's a very good question. No, we shouldn't do any testing before. There's no evidence that it's a protection. Preventive allergy testing doesn't give us any information. And this is also, and I'm sorry to jump to a different topic, this is something that is commonly done for medications. So some patients are randomly, before given an antibiotic, let's test a bit in the skin. That doesn't give us any information. That doesn't tell us if the patient is going to be allergic or not. So allergy testing, generally speaking, for foods and for other things, is a confirmatory test. So patient has symptoms that are suggestive of allergies. So we confirm that there's a mediated response, IgE response, by doing the testing, a skin testing or blood test. But not if we haven't been exposed, we haven't had a reaction. That is useless. That's useless.
So that means that the history is more important than the test. So the history, when it's done and it is suspicious of having allergy, the blood test or the skin prick test, it's only confirm the diagnosis.
Exactly.
But what if there is like the result is inconclusive? Will you go further with testing?
Mm-hmm. We have the next step of testing, which is oral food challenges. So we give a portion of food, not directly, not the whole serving, but we give small amounts at generally 20 minutes intervals, and we confirm if the patient has a reaction or not. And this is the gold standard for diagnosing food allergy. Yes. Mm-hmm.
So as I understand now, so like the food challenge, we do a lot of food challenge here in our hospital for different age group. What about the safety? Because sometimes the parents will be like worried about the safety of the oral food challenge, or even like the immunotherapy. So what do you say?
This is a question that I love. So food challenges are safe if they are done in the right environment. So we need to have all the medication available to treat reactions, and we really know how to evaluate the symptoms. Yes. So we need to be aware. We need to have trained nurse as the ones we have. Our team is fantastic. They are able to identify early symptoms. They are able to differentiate when the patient is stressed, because we all feel things that we might feel, something is happening, I'm reacting. No, we need to calm, we need to evaluate. But under the standard situation, with the proper team, with the proper medication, it's a very safe procedure. And what happens is, it's a very valid information. We are able to tell the patient, okay, you can eat this, or no, you should be avoiding. And we are able to identify if the patient reacts to tiny amounts, to traces, so really need to be reading labels, need to be very aware of any possible contamination, or no, if I eat a tiny amount, I'm fine. I cannot have 10 peanuts, but I'm able to have some,
2 pieces or 3 pieces,
yes,
for example.
exactly. So that's very valid information, and that improves patient quality of life, reduces stress, makes family life a lot easier.
Yeah, I like with the oral food challenges, very safe procedure, because we do like a graded doses. So we don't start with the big dose. We start from very small dose of the food item that we are testing, and then we go like every half an hour we increase the dose. So it's a pretty safe, and most of the time like it is done under our supervision. In case of any symptoms, or if we have suspicion that this is like there is sign of allergic reaction, we stop the challenge, and we stop the challenge basically.
And treat the patient, yes, right.
Okay, so.
And when we have patients that are already diagnosed of food allergies, and what can we do next? So we give the proper information, how to avoid the food. We teach them how to manage an allergic reaction, because accidents can happen, and patients can have reactions in restaurants, at school. So they need to know how to proper use EpiPen, epinephrine self-injectors, and we need to give all this information. But after that, we also have now treatments for food allergy that involve reducing this reactivity, this sensitization, and that is called oral immunotherapy. So with oral immunotherapy, we progressively desensitize the patient, so the patient doesn't react to the food. And we need to keep in mind that this is not a cure for most of the patients, in the sense that, okay, now I'm free to eat or doesn't eat. No, we need to keep a regular consumption, but it really protects against accidental exposures and reactions. So this is an alternative that we are able now to offer to our patients.
I agree, because like once it comes to the safety of patient, like the oral immunotherapy will be a really useful for specifically for the patient who have like allergy to traces of allergy. Plus like this, like the study of like the oral immunotherapy is evolving a lot and has been changing all the time, and now we have like better understanding on how to train the system, the immune system, to tolerate these food items that we are allergic to.
Very good. So what do you think, Dr. Hamad, of other allergies? Where is the earliest we should test a child? Is there any age limit, or we can do allergy testing at any age?
The allergy test, we can do it at any age. But again, as you mentioned earlier, we don't do like a screen testing. So we don't screen the patient for different allergen so we can introduce. Most of the time, we introduce these food items slowly under the supervision of the parents. And in case the patient develop reaction, then here we do the allergy testing. We can do either the skin prick testing, it's available. We can do also like the specific IgE. And now also we have like more advanced like testing, like molecular allergy testing that we have in-house here. And we can utilize all these resources in order to make the diagnosis.
And we've briefly mentioned that we diagnose patients with not just food allergy, but also respiratory allergies, allergic rhinitis, asthma.
Drug allergy is always
Drug
important
allergy is very
because most
important.
of the patients come with confusion. They think that there is like a blood test that we can do for the drug allergy, but it is when it comes to medication and drug allergy, it's more complicated because it's involved, like it depends on the medication that we are testing. Some of the medication we cannot test on the skin because it will cause like skin irritation, and for each medication has its own concentration, so it won't cause like false positive result because of the skin irritation. So we do the skin prick testing, intradermal testing. When everything is negative, we proceed with the drug challenge. So basically we give the medication to the patient and keep him under observation. Again, this is a graded challenge, so we don't give him the full dose at once, but we give it to him like slowly, and we monitor the patient for any sign of reaction. It is really good because most of the time we have a lot of patients who are labeled as penicillin allergy, and most of these patients, those patients, they don't have anything.
Yes, exactly. So I would like to really emphasize that we should be confirming when a patient has a reaction to a medication, and not just tell, oh no, you reacted, you had hives or you had a rash when you were taking amoxicillin, so you must avoid amoxicillin for the rest of your life. No, we should be confirming this, and if the patient has an allergy, a true allergy to amoxicillin, we should be looking for alternatives and what to offer, not just, avoid all penicillins, avoid all beta-lactams.
Yes, finding the alternative is also very important because most of the patients will be told that they have allergy and they got stuck. And whenever they go to the hospital or to their pediatrician, the pediatrician will be like kind of like helpless. It's like, oh, I don't know what to give this patient. Yeah. So it is always better to find the alternative for the medication that has been causing allergy in the past.
Very good. And one of the conditions that we also treat here is hereditary angioedema, right? What could you tell us about?
Well, hereditary angioedema, it's a rare genetic disease that has been causing like a swelling of different parts of the body. The problem with this disease, it can be lethal. So, it can be fatal. So it can cause obstruction of airway, upper airway, and can cause suffocation to patient. Most of the time, this medication, even in the US, so this is not only here, even in the US, so the delay in the diagnosis can take up to 11.5 years since from the onset of the symptoms. So most of the time, this disease, it goes around undetected and misdiagnosed, and most of the time the patient will be diagnosed as allergic to food or allergic to medication. But this is totally different, and usually like the patient will have a sudden like swelling of the face or different part of the body, abdominal pain, and usually these symptoms don't respond to conventional allergy medication like antihistamine and steroid, and usually they tend to take longer time to resolve. The good thing that we have now like really good medication that can treat this treat the symptoms, so it can control the symptoms of this disease, so the patient will have like a good control of his life and his daily activity. So I think now we came to the end of our session. So let's summarize it together. So again, allergy, it is very common in this region, so we are not like having less or more allergy in general, but some of the food items are different than what we see in the Western countries. We always encourage parents to early introduce food as early as early as 4 to 6 months of age, not to wait. and there is no pre-screening for food allergy before patient, like the child or the kid can start eating. No,
No pre-screening.
pre-screening.
Right.
And what else?
Whenever we suspect an allergy, we should see a specialist. Avoiding foods unnecessarily or avoiding medication just because we suspect we had a reaction is not a good practice. We should confirm, but we should confirm in a safe manner. We need to do the proper testing, and we need to address correctly and give the right indications to the patients.
Again, that the oral immunotherapy is an option for especially for the patient who have severe allergy, who react from traces. We have really good examples in our clinic. We tried it with different kind of food, and it's very important to emphasize that there is a window of opportunity. So whenever we do oral immunotherapy for food, the younger the patient, the better the outcome.
Exactly.
So the older the patient is less likely to reach a good outcome. But again, we always try to include everybody. But again, the earlier we start the oral immunotherapy, the better
best.
the outcome.
Generally speaking, it's really something to consider. So we shouldn't be postponing anything. We shouldn't be postponing introduction of foods. We shouldn't be postponing diagnosis if we have a reaction. And we shouldn't be postponing the treatment.
So now we have reached the end. So I would like to take the time to thank everyone who's watching us today in this episode. And if anyone have any query or any question about the service that we provide in the pediatric allergy clinic in Cleveland Clinic Abu Dhabi, so please visit the Cleveland Clinic Abu Dhabi website, or you can call the contact number for scheduling appointment or further investigation. Thank you. Thank you, Dr. Emma.
Thank you. It's my pleasure.